Hi, it's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered. And in last week's episode, I answered another question from one of our readers. And the question last week was, my husband is in ICU with COPD. Will he be able to wean off the ventilator? You can check out last week's question by clicking on the link below this video. In this week's episode of Your Questions Answered, I want to answer questions from one of my clients as part of my one-on-one consulting and advocacy service. And it's a general question, actually, we get asked quite frequently. And I want to answer it today in a specific blog post here. What is ventilator-associated pneumonia, also known as VAP? So, ventilator-associated pneumonia, also known as VAP, is a pneumonia that develops 48 hours or longer after mechanical ventilation is commenced on a patient by means of an endotracheal tube or a tracheostomy. Ventilator-associated pneumonia, or VAP, results from the invasion of the lungs by microorganisms. Intubation, which is the insertion of a breathing tube or an endotracheal tube, compromises the integrity of the oropharynx and trachea and allows oral and gastric secretions to enter the lower airways. Gastric secretions means basically stomach secretions. VAP is a subgroup of hospital-acquired pneumonia. Ventilator-associated pneumonia, or VAP, also applies to patients with an endotracheal tube or a tracheostomy tube, and it does not include patients receiving non-invasive ventilation, also known as NIV, or you might have heard of CPAP or BiPAP ventilation. VAP is a common complication in ICU, and it has a 15 to 20% incidence if there is ventilation for more than 48 hours. A gold standard test for diagnosis doesn't exist. So, what causes ventilator-associated pneumonia, or VAP? Here is the pathogenesis. Events leading to ventilator-associated pneumonia. Number 1, the colonization of the oral cavity, upper airway, endotracheal tube and circuit with pathogenic organisms. The passage of pathogenic bacteria from the above sites into the lower airways through aspiration or microaspiration of secretions and suction catheters. Endotracheal cuffs are effective at preventing macroaspiration, but small folds on the surface of the cuff act as conduits for microaspiration of secretions pooled above the endotracheal cuff. In older patients who may have tracheomalacia, there may be a leak around the cuff despite high intra-cuff pressure. Now let me quickly explain the endotracheal cuff. Basically, when a breathing tube is inserted into a patient's throat, the breathing tube is sealed with a cuff, right, with a balloon, and you inflate air into the balloon. It seals off the trachea and it stops basically secretions or gastric content to enter the lungs. But as we just discussed, there is still a small chance that despite the cuff being inflated, that there is microaspiration, and that can cause ventilator-associated pneumonia as well. So, next, what are the causative organisms causing the ventilator-associated pneumonia? So, again, greater than 48 hours in hospital, often community organisms. Within 48 hours to 5 days in hospital, It could be a mixture of community and hospital organisms. More than 5 days, often hospital-grown multi-resistant organisms such as methicillin-resistant Staphylococcus aureus, also known as MRSA, and gram-negative bacilli. Also, Pseudomonas, as well as Klebsiella, Enterobacter, and Acinetobacter, as well as Stenotrophomonas maltophilia. So, how to prevent ventilator-associated pneumonia? So, the implementation is the multidisciplinary team in ICU really approach with staff commitment, doctors, nurses, infectious disease team, physiotherapy, etc. The recognition of the problem determines VAP base rate in the unit. Identify interventions that improve outcomes, such as checking, for example, the endotracheal cuff regularly. Educate staff. Nursing education has shown to decrease the VAP incidence. Implement preventive strategies as a bundle of care with ongoing education and reminders. And audit feedback and results. Next, infrastructure and general measures. Infection control, hand hygiene compliance, cross-control of infection, surveillance, close communication. Antibiotic cover, adequate cover to reduce risk of methicillin drug-resistant organisms. Obviously, good staffing levels decreases cross-contamination. If you're in a unit, if your loved one is in an ICU where there's not enough staff, the risk for a nurse or for a doctor rushing from one patient to another and not washing their hands, doing the hand hygiene, and therefore cross-contamination happens. Also, look at the environment. Targeted environmental sampling, disinfection during outbreaks. Next, patient care. Prevent colonization of the upper respiratory and gastrointestinal tract. Good oral care. Use 0.12 to 0.2 chlorhexidine twice daily with a sponge swab or brushing teeth. Oropharyngeal decontamination or selective digestive decontamination reduces VAP rate, but generally not used due to concern over MDR, methicillin-resistant organism selection. Also important, stress ulcer prophylaxis only when indicated, i.e., for example, high risk, burns, traumatic brain injury or spinal cord injury, severe sepsis, coagulopathy, and those receiving steroids equivalent of hydrocortisone more than 250 milligrams per day, or active peptic ulcer disease. Also, silver-coated endotracheal tubes shown to decrease the rate of VAP. And also probiotics decreases ventilator-associated pneumonia as well. Next, preventing aspiration. Maintaining the head of the bed at 30 to 45 degrees unless contraindicated for such issues like a brain injury. Subglottic secretions drainage decreases VAP with a likelihood of 11% if ventilated for more than 24 to 48 hours, but when combined with head-up nursing, no difference has been observed. Maintain endotracheal tube cuff pressures between 20 to 30 centimeters per water, check every 4 hours. There is no benefit from ultra-thin or tapered cuff endotracheal tubes. Also, consider early gastrostomy if indicated, because it may decrease microaspiration. Why is that? It's simply because if there is a nasogastric tube, the risk for aspiration is just so much higher as opposed to a gastrostomy or a PEG tube. Next, minimize the duration of mechanical ventilation. Assess readiness for extubation daily. Optimize use of sedation and analgesia. Avoid oversedation, because it decreases the time on mechanical ventilation and therefore it decreases the risk of ventilator-associated pneumonia. Next, early mobilization. potentially early tracheostomy, even though there is controversy around that, because it's only applicable to selected patients, for example, neurosurgical patient, high spinal injury patients. And use NIV such as non-invasive ventilation, such as CPAP or BiPAP, if appropriate, because again, it decreases the risk of ventilator-associated pneumonia. Next, endotracheal suction, humidification, and care of the circuit. Endotracheal suction when airway secretions are present. Closed and open suction with a single-use catheter are equivalent. Humidification and heating of the inspired gases. HME filter versus heated humidifiers. Data is conflicting, considered equivalent if heated humidification with heated wire in the inspiratory or both limbs of the circuit is used to prevent condensation. Avoid routine ventilator circuit change. Frequent changes doesn't change the VAP rate. You can also find the references towards this article on our website by scrolling down below this video. If you are watching this on YouTube, just click on the link below this video where you get access to the written version of this blog and where you can also access the references. So, if your loved one is in intensive care, how can you become the best advocate for your critically ill loved one? How can you make informed decisions, get peace of mind, control, power, and influence quickly whilst your loved one is critically ill in intensive care? You will get to that all-important feeling of making informed decisions, get peace of mind, control, power, and influence when you download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn quickly how to make informed decisions, get peace of mind, real power and real control, and how you can influence decision-making fast whilst your loved one is critically ill in intensive care. Your free Instant Impact Report gives you in-depth insight that you must know whilst your loved one is critically ill or is even dying in intensive care. Sign up and download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions. Discover the many competing interests in intensive care and how your critically ill loved one's treatment may depend on those competing interests. How to eliminate fear, frustration, stress, struggle, and vulnerability even if your loved one is dying. You will get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power, and influence in your situation. You will get real-world examples that you can easily adapt to your and your critically ill loved one's situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You will get crucial behind-the-scenes insight so that you know and understand what's really happening in intensive care and how you need to manage doctors and nurses in intensive care, and it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I'll see you again next week in another update. Make sure you also have a look at our blog section for more tips and strategies, or simply send me an email to support@intensivecarehotline.com with your questions. Also, have a look at our membership site intensivecaresupport.org for families of critically ill patients in intensive care. You can also call me. Find international phone numbers on the top of our website. Also, have a look at our ebook section, where you get ebooks, videos, and also audio recordings, and where you can also get one-on-one consulting with me over the phone via Skype and via email by clicking on the relevant tabs on the top of the website. This is Patrick Hutzel from intensivecarehotline.com, and I'll see you again next week in another update.